Morning everyone. I hope you're well. Looks like we've got a few people live already. Good morning, Becky. Oh, you're hidden by that thing. Hold on, let me just get rid of that. Hopefully. Oh no, that's not working. Why is that not disappearing? There we go. There you are. Welcome. Good morning, Becky. And if anybody else wants to leave a message in the feed, then just pop it in. It should be either Facebook or on YouTube. Okay, so we've got a couple working this morning. Let me just sort this out a second, otherwise that's going to annoy me. There we go. We're back again. Cool. So welcome back. We've covered quite a bit last week to do with the connective tissue. Still got a little bit left to do on that one, so we're going to finish that off this week. Start building up some of the structures around the neurovascular area around the hip, and so it'll give you a bit of an idea of some of the structure around something called the femoral triangle. So we're going to have a look at that, and I'll just pop these up as well. They're all going down there for some reason. Weird. So if you're on Facebook and you're commenting on Facebook, it will come up as Facebook user unless you allow eCam. Let me just copy this. Your permission to use your name. So let me just add this onto the screen. There we go. So if you visit that site, then you should then look like this. There you go. Morning, Martin. And if you haven't done that already, then if you're on your phone, it may come up anonymous like that. Morning, Penny. Or like this, Facebook user. So good morning, whoever you are. Hope you're well. But yeah, if you visit that website, then you'll be able to get connected, and we'll be able to see who you are. Cool. Right, let's get going then. So let's try grab this PowerPoint. Here we go. So this is nearly where we finished last time. So we were looking at the ligaments of the coxal joint, which is the hip, and we were looking at this in particular. So let me just get around here. So this area in particular. So we've got the ligament of the head of the femur. So just this area here. So on the end of your femur, there's a little ligament on that. So imagine that's the ball. You've got a piece of ligament that attaches on the end of that, and that's got a blood vessel in it. And it's a branch of the obturator artery, which we'll have a look at later. And that artery then comes through that ligament onto the top of the femoral head. And if you can see that there's your growth plate line just there. So this is really important for kids. So if you, I think we discussed this last week anyway. Pain in kids is weird anyway. They don't usually get like sporting injuries and that kind of thing because they're quite bendy and they recover really easily. So if there's any symptoms, then it should raise some concerns. But this is quite common if you've had like an impact injury or maybe even something congenital as a child, and this area doesn't develop, and basically the femoral head doesn't get a blood supply, so then it starts to necrose. And we looked at hip dysplasia and a slipped epiphyseal plate, which is basically this area here. And that this will be one of the reasons potentially why that would occur is because of the lack of blood supply here. So if there's any kind of interruption of that, then the whole of the head doesn't get any blood, and so it will start to necrose. Basically, it will start to die away. So something to be aware of. Obviously, it can happen in later life as well, but it's something that's usually a juvenile thing that we would be concerned about. And here's the ligament itself. So this is the ligamentum teres. So one end of it on the head of the femur, and then the other end in the acetabulum, which is the socket of the hip. If you remember, acetabulum means vinegar cup, so it's shaped like a vinegar cup, from Latin, I think. And then we looked also at the ligaments here as well. So we've got these various different ligaments, depending on where they attach. So iliofemoral from the ilial region of the pelvis onto the femur, and then pubofemoral, so from the pubis onto the femur, and then around the back you've got your ischiofemoral ligament just here, and so from the ischial region onto the femur. Yeah, so all of those will form the ligaments of the hip. And I'll just show you this video from last time. It's that one. So this, excuse me, hopefully if it's going to play, okay, why isn't that playing? Let's just work that out. There we go. Okay, so this is the hip capsule. And basically those ligaments that you just saw on the previous image, this is what it looks like, and it's not easy to define. So here we are, here's the capsule. It's made of the ligaments that we've just seen. It's thinner underneath, so it's more kind of pleated underneath, thick and stronger everywhere else. So that this is what you see in the books, this is what it looks like in real life. So it just covers the whole hip joint, and you can just about make out the kind of differences in the shapes of the ligaments, but it's yeah, it's pretty tough basically. And the ligaments connect all the way around. So there's the socket, there's the head of the femur, there's the neck of the femur, and it covers all the way around. It kind of forms this sealed unit all around the hip, and it's a synovial capsule. So it'll be full of synovial fluid. Okay, so that's what that looks like. We saw that last week, so hence why I'm kind of skipping through it. And then this was your, let's just move me out of the way. This, if you're doing revision, then this is your snapshot. So take a screenshot of that. All three of the ligaments are lax during flexion. And we were talking about if you're going to dislocate your hip, then usually it's in a flex position with some kind of load. So, for example, being tackled in rugby, your hip is in flexion, and then someone else lands on you. There's a potential for hip dislocation. Otherwise, it's a pretty solid joint, and very, very unlikely to dislocate. Okay, so it's yeah, it's quite unusual if it does. There may be some other kind of pathology going on if it does. So this was the acetabulum. This is where we got to last time. So there's your vinegar cup from Latin, and the shape of it is like the socket of the ball and socket joint. Yep, that's your. This is where we got to last time, I think. So this is your labrum. Excuse me. So this ring of cartilage around here, we've got the articular cartilage, and then we've got like a labral lip on the outside. What that does is it deepens the socket. And we saw a video last week where you tried to pull the hip joint out of the socket, and it's pretty tough. And I think Becky said, if you imagine you've got some water between two panes of glass, and you try and pull those apart, it's really, really tough. And that's basically what this is like. Okay, so again, dislocation of this area because of negative pressure is really difficult as well. So that is that. And then we had a look at this. Hopefully this will play. Here we go. Yep, so this is the acetabulum, and you'll see the labrum as well. Hopefully. Here we go. So that's the area that we've just seen with the ligaments, and then you take the ligaments off, and then we see the structures underneath. So there's the labral rim all around there. So it's a C shape. It's not fully, it doesn't fully fill everything. And then there's the ligamentum teres just there. You can just see it poking through there. So this fossa area just means a dip. There's the labrum all around the outside. So the labrum helps to deepen the socket. And obviously we have got a labrum in the shoulder as well. It's the glenoid labrum. This is the acetabulum labrum. And then there's the head of your femur, and then there's the ligamentum teres on the other end. So that's where the blood supply comes through and feeds the head of the femur. Okay, cool. So we had a look at that last time. And we're going to go back to that in a second when we have a look at some of the pathology of the labrum. But before we do that, just want to include this inguinal ligament as well. So if you've not heard of this before, it is the bottom of your abdominal wall. Okay, so it's where your ab muscles attach into is the inguinal ligament. And when we start to move a little bit higher up, we start to move into the lumbar spine area. We do a whole session on like herniations around this region, because this is an area where there are structures passing from the abdominal cavity into the leg. Yeah, so they've obviously got to go through somewhere, and the openings that they go through are areas which are susceptible to herniation. So we'll have a look at that next time. Just pop that in there. Yep, so teres means round. So it's kind of a circular ligament. Okay, so that's what teres means. That's a good question. It's like the teres major and minor. They're kind of round muscles. It's just the shape of them. Good question. Cool. So this is what you'll see in all your books. So there's your pubic bone, pubic symphysis just in between the two pubic tubercles. Then up here we've got the ASIS, so that's the bit on the front of your pelvis that you can feel. And again, we talked about this being different sizes from side to side. Okay, we mentioned that a few weeks ago. And then this is the inguinal or inguinal, however you want to pronounce it, ligament that goes across the top. And then your abdominal muscles will attach into that area. Okay, so into that ligament. And there are certain gaps between the abdominal wall and the inguinal ligament where, depending if you're male or female, you'll have tubes basically going around this area, and so there'll be holes around the inguinal ligament. And the reason why males are more susceptible to inguinal hernias is because of the spermatic cord that goes down to the testes around here. So that we'll cover that when we get to that region. So keep that in mind when we talk about this inguinal ligament again. But also, it forms a roof for these structures to come underneath as well. And I've forgotten to change it. These are in the wrong place. So that's iliacus and that's psoas there. So those two are in the wrong way around. Still haven't changed that PowerPoint, sorry. So you've got two big muscles that come over this region from behind that ligament. So this one, the iliacus, comes from the this region here. Okay, so all on the inside of your the wing of the ilium. And then your psoas muscle here, that comes from your lumbar spine. So they travel from behind the inguinal ligament and then underneath it. Okay, and then it's joined by a nerve, an artery, a vein, and then some lymph nodes. Okay, so we've obviously talked about those over the last few weeks. So the femoral nerve is obviously it's always yellow. Okay, so there's your femoral nerve, femoral artery, the red one, and then the femoral vein, the blue one. So this is the neurovascular bundle. So neuro, obviously nerves, vascular is to do with the circulatory system. So neurovascular bundle travels underneath the inguinal ligament. So the way to palpate the femoral artery, if you want to feel a pulse, you put your hand on your pubic bone, you put the other hand on your ASIS, okay, so hand on the pubic bone, hand on the ASIS, and then halfway in between, you push into that region there, and you may have to be lying down for it. It's a bit easier to feel when you're lying down, but you'll be able to palpate the femoral artery and the pulse because it's quite superficial. Okay, it's really, really close to the surface. So that's inguinal ligament from your pubic tubercle to the ASIS, and then you've got the nerve, artery, and then the vein all running underneath there. So we're going from, this is the region, so beyond that inguinal ligament, where the names of the vessels change. Okay, so they'll be called different things when we move up into the pelvis. All right, so just to be aware of that, similar to what we've encountered in the knee. Okay, so this femoral artery here, because it's in the femoral region, so the femur region, will eventually become the popliteal artery, which is behind the knee. It's exactly the same artery, it's just given a different name when we get down there. Okay, cool. So that's that, and then that kind of leads us then into this femoral triangle region, which is where the inguinal ligament is at the top. Okay, so it's one of the borders. So this is the inguinal ligament region here. So we've got the connective tissue and muscles attaching into the inguinal ligament. Then we've got this triangle shape here, just there. It's formed from different muscles. So we'll have a look at those in a bit more detail as we go into the muscles. But if you may have heard of some of them before. So we've got one of the borders is the sartorius. So this one here, this is this muscle coming across here. And then the adductor longus is the other border. So just there. So we've got that border there, the inguinal ligament at the top, and then the sartorius coming across. And that forms the femoral triangle. Okay. And then within that triangle, this is where your nerve, artery, and vein reside. Okay, so they're quite vulnerable in that region there. So if you do manual therapy and you're using your elbow to massage someone's quads, you've got to be really careful around this area here, because if you irritate that nerve there, then it may change the sensation in the quads, but by compressing that nerve. And it will be quite sensitive as well around this region here. Okay, so just to be aware, they're not being a wuss. You've got a very superficial nerve, artery, and vein around that area there, so they may not like deep pressure around that region. Okay, so something to be aware of. Cool. And the way to remember it is by navy. Okay, so you've got your nerve, then you've got your artery, then you've got your vein, and then obviously in the 70s, well, maybe they're making a comeback, you never know, then you've got your Y fronts. Okay, so if we go back to this picture here, there's your nerve, there's your artery, there's your vein, so NAV, and then your Y fronts would be there. Okay, so a nice little way, well, I say nice way, is a way of remembering the order of those vessels, okay, in that femoral triangle. So again, if you're doing an exam, that's one to remember. Okay, cool. So let's have a look at the inguinal ligament. Let's just do that one. Here we go. Yeah, you'll never forget that now. Seeing an image of blokes in Y fronts is just ingrained on the memory forever, I'm afraid. Right, here we go. There's the inguinal ligament, just there. And then there's the gap underneath where all the muscles and the nerve, artery, vein come through. ASIS just there. And then the pubic tubercle just here. Okay, so you can see some of the muscle tissue still attached. Oh, here we go. So here's the external oblique fascia. This is what it looks like with nothing removed. Okay, inguinal ligament is underneath there, so everything is all attaching in there. Tensor fasciae lata as well, another muscle attaches into there as well, and there's a gap underneath where the nerve, artery, and vein will come through. There we go. So there's iliacus, there's psoas. Okay, so that, apologies for the last one, they're the wrong way around. So there's iliacus, there's psoas, and then nerve, artery, vein, and then your Y fronts. Just go back there again. Just have a look at that again. So this is without any tissue removed. That's what it looks like. And then that's with everything taken off. You can see this structure here. And then underneath, iliacus, psoas, nerve, artery, vein, and then your Y fronts. Hence the photo. Okay. It would be good if they were the t-shirts and underwear were coloured yellow, red, and blue as well. Never mind. We're going to have to do that photo shoot again. Okay. Right. Let's have a look at this one. Get rid of that, you'll be glad to know. Okay, cool. So yeah, we're moving on to the next section. Oh, in fact, before we do that, let me just grab this. For some reason it hasn't teed up that. Let me just grab that PowerPoint. Here we go, hip pathology. Cool. Just pop that in there. Yeah. Okay, let's have a look at this then. So we've had a look at all these last time. Let me just that was a good source of discussion last week, and then we're going to have a look at the connective tissues. So last time we had a look at the hip joint pathology. So what can go wrong with the acetabulum and the head of the femur, and the kind of pathology that you might get. Again, I mean, we're not going to cover all of it, but some of the common ones. And these are some of the injuries that you may get to the labrum. Okay, so I just thought I'd show you this. This was the paper that I posted in response to Simon's question in the group the other week. And I was saying about the prevalence of these anomalies. Okay, so just because you have a cam or a pincer lesion, it doesn't mean that that's the reason for your symptoms, because quite a few people have these changes. Okay, it's like other areas of the body as well. So this paper is from 2012. It's the prevalence of abnormal hip findings in asymptomatic participants. So 45 people with no history of hip pain, no symptoms, no injuries or any surgery. Okay, and what they did was they MRI'd these people. They had a range from 15 to 66 years old, a mean age of 37. And if we have a look here, labral tears were identified in nearly 70% of hips. Okay, so what we're just about to talk about, 70% of people who are asymptomatic have these problems. Okay, well, problems, they're normal findings. Okay, you're more likely to find them than not. Chondral defects are to do with the surface of the bone, so the articular cartilage surface. Ligamentum teres tears in 2.2%. Okay, so that ligament we were just talking about, 2.2% of these people that were investigated had tears in that ligament and were asymptomatic, didn't have a problem. 13% had cysts, so this is labral cysts. Those are quite common. Acetabular bone edema, so that's swelling on the acetabulum. Okay, so they identified some kind of swelling. Fibrocystic changes in the head and neck junction. Okay, so again, fibrosities around that area. Fractures in 11%. Mad. Yeah, so over 10% of people had fractures and they were asymptomatic. And again, you can read on a bit more. I'm not going to go into all of that. So magnetic resonance images, so MRI of asymptomatic participants revealed abnormalities in 73% of hips. Okay, so you are very likely to have these changes. Again, it's one of those things we've talked about. Normal and not normal. These are the things that are that are seen quite frequently. Okay, in asymptomatic people. So this is from this paper back in 2009. So this is a comprehensive review of hip labral tears. So this is what we were just looking at on the video. So we've got the labrum and the articular surface, the ligamentum teres, and then the head of the femur just there. So the etiology of labral tears, which is basically, etiology is like the story of how it happened. Okay, so the story of labral tears is usually trauma. Okay, so some kind of impact or fall. Femoroacetabular impingement, so some kind of squashing in between the femur and the acetabulum, so the head, the ball and socket basically. Capsular laxity or hip hypermobility, so that's those ligaments we were just looking at, the ischiofemoral, iliofemoral, pubofemoral, all of those form the hip capsule, and if there's a laxity in those, then they don't hold the hip joint in place as well. Okay, so that's one of the reasons why you may get labral tears. Hip dysplasia, which we talked about last time, so that's where the socket is usually shallow, or degenerative changes. So as you get a bit older, we just see the changes anyway. Okay, so those are the stories behind the usual stories behind why you get a labral injury. And then there's different classifications depending on what has happened to you. So just move that out of the way. So the classifications can be by location. We'll talk about that in a second. The etiology, so how it happens, and that's what was on the last slide. And then the morphology, so the kind of structural differences. And the morphological classifications are a radial flap, which is like that. Okay, so a tear that way. A radial fibrillated, so where it's kind of it's like a scuff mark, basically. Yeah, fraying. There we go. Associated with the degenerative joint disease. Longitudinal peripheral, which is this one here. That's kind of where it's been pulled away. Okay, and then abnormally mobile. So basically an unstable. Okay, so it's like properly detaching. Okay, so those are your classifications morphologically of the type of labral injury that you may get. Okay, and then these are the locations, so they can be superior, anterior, there's nothing inferior really apart from the edges of the labrum here and here, and then posterior. And the most common area to get them is anterior superior. It's kind of around that region there. Okay, so yeah, so that's how labral injuries are classified. And then how they present is usually with anterior hip or groin pain, and that's really key. They'll usually say it's my groin, so they'll point to the front, and when they say it's my hip, they usually point to their glutes. So that's a good sign if they're pointing to their glutes, because it's obviously more of a gluteal problem. And when we get to the muscles and we look at the gluteal region, then we'll have a look at some of the pathology there. And then frequently with mechanical symptoms as well. So you're going to get clicking, locking, or potentially giving way, because when something is quite painful, and the outer areas of the labrum are quite well innervated, so they've got a lot of nerve endings. So if something's really sore and it catches, then it just knocks out your muscles. So then you kind of it gives way as you go. Okay, and a clicking and a locking, hopefully you can see how that would occur now because of those little flaps of labrum that will come off and into the joint, and that's why it clicks and locks. Okay, so this is why, I mean, people keep on saying, oh, you don't need to learn anatomy, yada yada yada, and I think to understand pathology, it's really useful to understand the anatomy and then how that can get injured, because it just makes sense when people are coming in saying certain things. You go, oh, that sounds like that. Okay, so that's your labral injuries. Okay, so a bit of an overview of those. Right, let's have a look at this. So now we're going to move on to the bursa and the muscles around the hip. So we've had a look at the bones. We've then added on the connective tissue layer. And then after that connective tissue layer, we're now going to add on the muscles and something called a bursa. So we're going to have a look at the bursa first. Really often misdiagnosed this is. So if you have pain on the outside of your hip, and this is tarring out all of them with the same brush, so, and I know there are good ones and there are not so good ones out there, but if you go to the GP with pain on the outside of the hip, they will usually tell you you have a trochanteric bursitis. The problem is, though, that is often not the case. It's usually something else, and we'll explore that as we go through. But also, you can say which trochanteric bursa, because there are lots of them. Okay, so these purple things here, these are the bursa, or representing the bursa, and if you have a look, they're in between muscle layers and also in between the bone and the muscle there. So what they do is they provide a friction-free surface for muscles to run over, so that, I mean, if you imagine that wasn't there, then it would just be muscle on muscle, and then because they're moving so frequently, they would start to fray the edges of the muscle, and it would start to become fibrotic. But so the body, in its wisdom, have developed these bursa, which are fluid filled, and it's basically like having a balloon with water in, obviously a very small one, in between those surfaces, so that they can roll over each other and there's no friction. Okay. The way to irritate these areas, because you can get a bursitis, which is an inflammation of the bursa, it's usually via a direct impact. So if you've fallen onto your hip and you've hit the outside of the hip on quite a hard surface, then you can injure you can irritate the bursa, and it will become swollen. So I'm not saying that doesn't happen, but unless you have that kind of trauma, then it's unlikely that it's a bursa that's causing the problem. Okay, so okay, just lay that out there. Yeah, so this is what one looks like. Just move me out of the way again. When they're inflamed. And you're more likely to see them like this in areas that are quite superficial, so like in the elbow, hence the reason to get this picture. They can be quite swollen in the hip as well. But because of all of the connective tissue and all of the big muscles around there, they become quite contained, whereas in the elbow, they just get massive. Okay, I've seen a bloke with bilateral bursitis on the olecranon, and yeah, they were huge, absolutely huge. So what bursa means, a purse. Okay, so it's like if you imagine opening a purse, filling it with a fluid, closing the purse up, sticking it in between a muscle and a bone. There you go, there's your bursa. It's usually between something and a bone. They look a bit like a joint capsule, but are not lined with synovial fluid. They have a thick fibrous outer layer and are filled with bursal fluid. Okay, and it's that bursal fluid that can become inflamed. Okay, they cushion the movement between structures where a lot of movement takes place. And one of the reasons why people often get this kind of swelling here is because of leaning on the elbows. Yeah, we used to call these student elbows. So studying at your desk, obviously beavering away there, doing your work, and irritates the olecranon bursa, and then you get this big bursitis. Another area where you get it is like this is usually the pre-patellar bursa, so the bursa that's on the front of the kneecap, and it's quite common in people who work like carpet fitters and plumbers. So they're always on their knees, and it will just irritate that bursa, and they come up massive. That was often called a housemaid's knee. Okay, I don't know whether that's politically correct to say that now, but there we go. That's what you'll see in the books. So that's what they look like when they're inflamed. The bursa of the hip of the pelvis, like I said before, it's not just one bursa. So this is what you'll usually see. You go trochanteric bursa, there it is. Okay, but that's not the case. So if we have a look at this study here, what they did was they had a look. So a total of 106 bursa were identified in 10 different locations. So this is when they had a look at the cadaveric models. So they had a look at some dead bodies. There was an average of 6 bursa per hip. Okay, so this is where I say, well, okay, I've got trochanteric bursa, which one? Okay, because there are usually 6. 4 bursa were present beneath the glute max muscle and the fascia lata, including those normally thought as the trochanteric bursa and the gluteofemoral bursa. Okay, and then 2 more bursa found beneath the tendon of the glute medius muscle, the anterior subgluteus medius bursa, and the piriformis bursa. Okay, interesting. So we've got some bursa around that region as well. And then in the majority of cases, a single bursa was located deep to the glute minimus, although two different bursa were identified. There was a glute minimus bursa and a secondary gluteus minimus bursa. So there are loads, okay? And it's quite common to have lots. So it's not just the one. Again, anatomy brings up some surprises for us. It's not as simple as we often think. So this is a nice image. So we've got a subgluteus maximus bursa there. Then you've got your greater trochanter. Then we've got one that's underneath the glute medius, just there. Then we've got a piriformis one, just there. Okay, so there's loads of them all around the hip. Cool. Then we've also got some at the front of the hip as well. And this may be an issue again that you think is a labral problem because of where it's located. So we've got the iliopsoas bursa, which is also known as the iliopectineal and iliofemoral. And again, these are named after the location. So iliopsoas is basically where the psoas overlies. There's a muscle called pectineus, which I haven't had a look at yet, but that's in between the ilium and the pectineus. And then iliofemoral is just ilium and femur region. Okay, so all of those are the same bursa. Okay. Just had a couple of questions come through. How long did the bursa last for before you are not able to see them in cadavers? So it depends on how they're set, for want of a better word. So if they are set in formaldehyde, then they're pretty much gone straight away. If they're fresh cadavers that aren't set, because sometimes they do what's called fresh frozen dissection, so they'll freeze someone straight away, and then as they're thawing, they'll start to dissect so they're as real to life as possible. And it will be in that kind of study where they will have found these bursa. And then Becky, can I add that? Yep, there we go. Am I right in saying that the body can grow new bursa depending on movement patterns and load? Yes. Yeah, seen various different bursa in areas where you don't normally see them. They're not in the books. So for example, seen some between the semimembranosus, semitendinosus tendon in the hamstring. We were doing some imaging and we were like, what the heck is that? That's not in the books. And yeah, we determined that it was probably a bursa. So if there's quite a lot of friction in an area, then the body will develop bursa, but to protect the structures. Yeah. Cool. And then we've got more bursa. Okay. So we've got trochanteric. And then the 6 around there, gluteofemoral, which we talked about as well, and then we've got the ischial bursa on your sit bones. Okay, so again, a kind of tendinopathy of the hamstring, so high hamstring strain, or what you may think is like a sacrotuberous ligament issue. It could be an irritated bursa. Okay, and again, without imaging, it's just guesswork, really. So, but there is a bursa in that region that could be irritated, especially if you've had impact on your bottom. Okay, so if you landed on your bum bones, again, potentially you can irritate that bursa, and it will start to swell. And as it swells, it just irritates the structures around it. Okay, cool. Not sure which one you meant. Sorry, is that the one the yoga people get? I'm not sure which one you mean. If you if you let me know, then I'll. To be honest, I haven't heard of anything specific to yoga, but I'll probably be able to work it out depending on which one it is. Cool. So last thing for today, we just do a couple of minutes on this, I think, and then we'll break for next week. So there are 10 muscles in your gluteal region. Okay, we've got 6 which are deep posterior muscles, and then we've got 3 gluteal muscles, and then the tens fasciolata. The last one. Let's have a look. The ischial bursa. Potentially, I guess, with some of the movements that they do, where kind of stretching hamstrings may compress that bursa potentially, but I would imagine it, because it's less impact and more positional, I would say it's probably a tendinopathy rather than a bursa issue. Yeah, but yeah, that's a really good question. Martin, are these only available to view on imaging when swollen around the hip area? Yeah, and anywhere else as well. So literally, like in the shoulder area, if you're doing a scan of the shoulder, you shouldn't see the bursa. You shouldn't, because they're very, very thin, and you literally only see it when it's swollen. Yeah, so that's a really good point. Yeah, no problem at all. Cool. Good. Okay, so 10 muscles split into different areas. Okay, so deep and then more superficial. So let's have a look at those. So the deep posterior muscles, I've called them the rotator cuff of the hip, because they're all involved in rotation, and all from a very, very similar kind of area. And they're often the ones that are blamed for deep gluteal problems. So we don't really call it piriformis syndrome anymore. And the reason why is because we haven't got a clue that it's piriformis that's causing the problem. There are lots of other muscles in that region. So now we call it a deep gluteal syndrome, because that's more accurate, because we haven't got a clue. Okay, so yeah, deep gluteal syndrome is piriformis syndrome now. That's the accepted term. So the first one we're going to have a look at is the gemelli muscles. So Gemini means twins. So we've got a similar location and the same action. So basically we've got two muscles that do exactly the same thing, and they come from a similar region as well. So if we have a look at those, and then we'll leave the rest for next week. Okay, let's have a look at this. So we've got this one here. Well, they're split into inferior and superior. So this one is superior, and the origin, insertion, action, etc. for both are exactly the same. Okay, so the origin is the ischial spine, and if you remember that from a couple of weeks ago, do you remember the greater sciatic notch and then the lesser, and then in between there was this sticky out bit there? That's called the ischial spine, and that's where your gemelli muscles attach. Okay, so from there onto your greater trochanter. So this is on the back of the pelvis. So bearing in mind that muscles can only contract, they can only shorten. So if you have an attachment point here and an attachment point here, and you contract that muscle, then that's the action. Okay, so it will laterally rotate the hip, it will rotate it backwards. Okay, so, and that's obvious to see. Yeah, so from there to there, you shorten that muscle, it's going to spin this greater trochanter backwards. Okay, so that's what that muscle does. And then the inferior, so there's the ischial spine, so that's where the superior gemelli is. This is the inferior gemelli, just there. This is the from around the ischial spine area, but not just a little bit lower, so it's more ischial tuberosity. Again, onto the greater trochanter, and again, if you have a look at where it goes from and to, slightly lower than the other one, so that's why it's inferior. And if those 2 points come together, you're going to get that external rotation or lateral rotation of the hip. Okay, cool. Right, let's have a look at those, and then we'll call it a day. Ooh, that's a bit scary. Don't want to see two of me. There we go. Okay, gemelli inferior and superior. So this is what they both look like in real life. Here we go. Okay, cool. Now that one, that took me ages to label up. So we've got sacrotuberous ligament just here. So we talked about that over the last couple of weeks. Ischial tuberosity was back on week 1. Then you've got these muscles we've not heard of yet, obturator muscles. Okay, and yeah, these muscles are more superficial than what you're just about to see. Okay, so these lay on top of the gemelli muscles. So be prepared in a second, they're just going to disappear. There they go. Okay, so now these are the ones that are underneath. So there's your superior and there's your inferior. So can you see that they look like the same muscle, don't they? But I guess if you dissected them down and had a look at them microscopically, you'd be able to see fascial divides in between the two. But if you just look at them as they are, they look like exactly the same muscles. Okay, so there's your points that they attach to. So ischial spine, and then just below the ischial spine on the ischial tuberosity area. And then they both come through and attach onto that greater trochanter there. So again, you can see that if those 2 points come together, you're going to get external rotation of the hip. Cool. Right, done. Covered quite a lot today. So that was recap of labrum, having a look at the injuries of the labrum and the way that it's classified. So the morphological classifications are how they're injured, the locations of them, and then the etiology as well, so how they happen. And then we went on to the bursa, had a look that there are about 50 million bursa in the hip, and then onto the muscles. So we're going to continue. We'll do a quick recap of gemelli next week, and then we'll go a bit further into those rotator cuff muscles of the hip. Okay, cool. Oh yeah, I forgot. Is there a session on Easter Monday? I'm afraid not. No, I'm on holiday on Easter Monday, so it'll be 2 weeks. You've got so if you've got a bit of catching up to do, then you can do that over the next couple of weeks. And yeah, so I'll see you in 2 weeks' time. All right, take care. See ya.